thank you all for joining us today. We really appreciate it. So if you didn't know, you are here on the Calm Waters AI webinar, mid-year coding checkup. Are you comfortable or are you confused? And if you're confused, we're going to make you comfortable today. And then without further ado, I'm going to introduce my two very knowledgeable experts I have here today with us. So first and foremost, we have Joe Ferro, who is our president of Calm Waters AI. Thank you, Joe. And then we have Nancy Entwistle, who is our EVP of Regulatory and Coding Compliance, who has more commas and acronyms behind her name than I think I've ever seen. So you know you're at the right place. So first, I'm going to turn it over to Joe just to tell you guys a little bit about Calm Waters, and then we'll dive into the coding content.
Awesome, Brandy. Thank you so much. And thanks for being here. We love having you, especially in the middle of summer. So just real quick, Joe Ferro, president of Calm Waters AI. And the whole goal today is to bring you hopefully some kernels of information around E&M coding, leveling, and the opportunities and capabilities that the 2023 guidelines are giving us. So we're obviously Calm Waters AI, and we deliver an autonomous EMR integrated E&M coding system. So right from your doctor's desktop, with the goal of automating E&M leveling to bring order compliance and standardization to the process. So that's the company, but let me turn it over to the medical records coding expert with Nancy. Nancy, thank you so much.
Thank you, Joe. I appreciate it. Excuse me. Hi, everybody. Thank you for joining us today. I know it's a busy Thursday for you, so we wanted to get some information out to you to try to help you. We're halfway through the year, and I think that we're finding where we may or may not be in any better spot than we might have been in January or February. So we're hopefully going to help clarify some of the still continuing pain points with the documentation as we are finding them. So why are we here today? We're here to cover some office visits with procedures, AWV, which is the annual wellness visit for Medicare, commercial annual visits, along with any sick visits. So the AMA has required that providers now see patients more succinctly in the office. Instead of having them come back 2-3 times, they're allowing them to do multiple service on one given day. So those are some more pain points that we're still seeing, that providers may or may not be aware that they can do multiple things all on the same visit any longer. We also have a lot of pain points about visits surrounding injections of the same site that the note is. So we want to kind of touch point on that. And other pain points of documentation, maybe some time issues, over the counter versus prescription drugs. So those are some of the things that we also want to kind of delve in today, including additional issues around the MDM, medical decision making, that we're still finding is an issue for some providers. Next slide, please. So again, just as a review, some old ways of documenting prior to January 1st, we had a full review of system, ROS. We had to hit at least 10 system types, and then providers would copy and paste to bulk up the notes to try to get more documentation in these notes. I'm not saying these things are not still happening. However, these are things that were happening in order to get the 95, 97 criteria to be compliant. Once we went live in January of 23, we no longer need these components necessarily to get to the necessary MDM components. 27% of the charts are still being improperly leveled, or they're considered not codable. So that's still 1/3 of the patient's notes that the providers are seeing are still having some major issues. So it's clearly an issue that is still pain points for many people. Next slide. So some of the new ways of documenting, we have face-to-face time and non-face-to-face time. Now, what does that mean? It's the face-to-face seems obvious. It's the time that the provider or qualified healthcare professional spends with the patient directly face-to-face. Non-face-to-face time is when the provider does work before the patient is seen and actually can now receive credit for that, as long as it's documented as being done on the same data service. Medical decision-making. The AMA is very concerned about the level of documentation about the patient-centered care. So they want to make sure that the provider documents appropriately and that the patient's care is being appropriately documented this way. Labs and radiology visits. So we can count for that as long as it's properly documented. We can count for the ordering and or review of this information. Again, it has to be documented as such. And prescription medications. There's a big documentation issue. Is it over the counter or prescription? If it is a prescription, it's being reviewed, it's being discussed with the patient. It is allowed to be considered as part of the MDM. Next slide. Coding tips, coding documentation tips. Now, I'm not sure who is exactly on the presentation, but I do know that if we have any coders, they are going to try to talk to the providers and get the best documentation available. So I want to try to give you a little bit of tips to help you do that. Remind your providers that documentation should be clear and concise. This is an item right out of the AMA. They want the information to be as clear as possible and as to the point as possible. They do not want the overabundance of word verbiage to bulk up the notes. They want to know the bullets, what's happening. However, as a side of caution, they don't want it to be so short that there's ambiguity in the note. They want to make sure that it is understandable for the patient of what was handled during that visit, as well as the treatment plan. Medicare annual wellness visit or commercial annual wellness visit. This needs to be documented in the note itself. What we're finding is that the provider is going based on the visit type registration, and sometimes that's not accurate. The provider needs to be reminded that in the documentations for it to be compliant, it does need to state that the patient is here for a Medicare annual wellness visit, or they're here for their annual visit. If it's not stated as a Medicare annual wellness, it is considered a commercial insurance. So the provider does not need to say this is a Blue Cross or a Tufts annual wellness visit. They just need to say they're here for their annual visit or they're here for their Medicare annual wellness visit. So that's a piece of documentation, if you could let your providers know, would be more compliant in their overall notes. Annual wellness visit, whether it be commercial or Medicare, with a sick visit. Again, AMA's goal on this is to have patient-centered care, and they do not want to have the patients, coming back for more than one visit if it's not necessary, when things can all be handled in one visit slot or scheduled time. So if you're seeing your patients in an annual visit and they have other issues that are outside of the annual visit components, please document that, and then you're able to bill for that as well. MDM, medical decision-making versus time. Either is correct with this new criteria. As long as it's documented as such that if you spent more time than documentation, the time needs to be documented. So if you saw the patient for 52 minutes, but your MDM only gets you to a level 3, your time is going to get you to that level 4 or level 5, depending on how much is actually cited in the notes. The CPT E&Ms have very detailed times of how much time is per E&M visit. So depending on the type of service will depend on the criteria of that time component. And then discussed and reviewed. It is no longer to be assumed that you have discussed something with a patient. It does need to be documented and or adversely reviewed. If you reviewed test results, or you reviewed a past medical note, or you reviewed an emergency room note with the patient, document that in your note. And then those are all tips to help you get to better documentation. Next slide. So some things to remember. This is a very busy slide, so I'm just going to kind of touch upon this, but this will be available for you to review after. Again, telehealth is one of those pain point issues, and it requires a time documentation to support the level. Also, you need to make sure that the telehealth is documented by audio and or audio visual. Audio visual meaning video and audio components. Those are the types of modality. They're called modality to make it more compliant note. Modifier selections also need to be done by practitioner and the coder. AWV annual must stated. I'm going to these things again. It just bears repeating to make sure that it is in there as a component. Home health levels, for those of you who are doing home health, MDM and or time can be documented as long as they are both, the documentation will support it. And it is unacceptable to bill for an annual visit and a sick visit. I'm sorry, it is acceptable to bill for an annual and a sick visit at the same time. Next slide. Now, some things that do not count towards our levels. Review and discussion of over-the-counter medications. There's an issue going that, I'll give an example, ibuprofen. It can be bought over the counter, but some providers still prescribe a higher level. Again, the difference is that what the insurance will or will not pay for is considered an over-the-counter versus prescription, or what the coding criteria that is acceptable for prescription medication. So that is an issue that you need to make sure that you're aware of. What is a coding rule and what is a payer payment rule for the insurance company? But the over-the-counter by itself, as far as medication, do not count towards our levels. Visits that are injections only do not require an E&M. If you're coming in and the site located is for a knee and the patient's coming in for a knee injection, no E&M level is applicable because they're only coming in to be serviced for that knee. Notes that are being brought forward, copy and paste. Any lingos that will basically bring forward the note. If the note is being brought forward, that is acceptable. However, it must be documented that these items are still concerning and that they were reviewed and discussed with the patient. You can no longer just copy and paste notes and count it as part of the overall note. And finally, lab values. This contributes to the level of risk, but it needs to be documented by the provider to apply for a level. So as just stating that I reviewed the lab levels does not indicate compliant language. You need to indicate that you reviewed the lab levels and that based on that MDM or medical decision-making and or prescriptions were prescribed due to whatever levels that they are. Qualifying time. Practitioners cannot count time for the following. Performance of services that are reported separately. So if you have radiology in your office and it's part of your practice, you cannot count that separately. Travel, if you're traveling to or from the patient or traveling to and from an office, between offices, you are not allowed to count that as time. And then teaching physician roles. As a provider, you're in your teaching facility, you cannot count the teaching role as part of your overall time. Modify 25. So for the coders in the room, you either love or hate this or a little combination of both. They like to change the rules, or they seem to change the rules of what they will or will not cover. But as far as the coding guidelines, it is applicable to report a separate E&M service as long as the E&M component must go beyond which is normally included, example, in an injection service. In other words, the E&M service must meet the definition of using the modifier 25. And this was right, that I took, as you can see, this was retrieved from AAPC Knowledge Center. So modifier 25 is applicable to highlight any services that were done above and beyond the normal practice of what was already being documented. So unique testing. This is something else that we seem to be getting a lot of questions and concerns about. Unique testing, as defined in the CPT book, is when multiple results of the same unique test, example, serial glucose values, are compared during an E&M service. They only count as one unique test. So just because they ran 6 or 7 sugar glucose values, you don't think that is one overall exam. Tests that have overlapping elements are not unique, even if they are identified with distinct CPT codes. An example of this would be a CBC with differential would incorporate a set of hemoglobin, CBC, without differential and platelet count. Now, when you run a panel, they're all components of the same service. So they are overlapping, and you cannot count that as specific unique values. A unique source is defined as a physical or qualified healthcare professional in a distinct group or different specialty or subspecialty or unique entity. And what this means is that, say you have a group of orthopods in a building, but this group services major joints, where this group services pain management. The second group that services the pain management is considered a unique professional in the unique entity. So even though it's one building, they have two groups under that umbrella, and they're considered distinct specialties. Review of materials from any unique source counts as one element towards an MDM. So if a patient was admitted to a hospital, you cannot count each note within the admission as separate unique sources. It's all one. So the emergency room, the H&P, the discharge summary is considered one unique source because it's all from the same admission. However, if the patient was in the emergency room 3 different times, they're 3 unique sources because those are 3 different service dates. Next slide. This is another thing that we're finding mid-year causing a couple of pain issues. Acute uncomplicated illness or injury. It seems pretty straightforward, but it really isn't. And we needed to explain this a little further. A recent or new short-term problem with a low risk of morbidity for which treatment is considered. These would be your simple sprains. An 8-year-old falls off of a jungle gym, comes in and sprained ankle or sprained wrist. That's a short-term problem, low risk, not really major. Surgery is considered hopefully for a minor sprain. There's little to no risk of mortality with treatment, and full recovery without functional impairment is expected. Again, these are your minor scrapes, bruises, things that you would see in an acute clinic that, maybe you have an overly cautious parent. They want to make sure that the patient's okay. A problem that is normally self-limited or minor, it is not resolved, but is not resolving consistent with definitive and prescribed course, and has an acute uncomplicated illness. Examples of this is a little bit more severe than acute bumps, bruises, and sprains. This would be more your cystitis, allergic rhinitis, or simple, and it's including your simple sprains here. We see a lot of allergic rhinitis, allergies, asthma, exacerbations. So that would all be acute uncomplicated illnesses. And here we have our stable chronic illnesses. For a problem with an expected duration of at least a year or until death of the patient is considered stable chronic. In the past years, we've never really had a definition about a chronic that we could go across the board with. For this purpose, defining chronicity, chronic conditions are treated as chronic, whether or not the stage of severity changes. Uncontrolled diabetes and controlled diabetes are the same single chronic condition. And that's something that needed to be a little bit more clarified. People feel that uncontrolled diabetes could be more of an acute issue, but this definition indicates that it is uncontrolled and controlled as considered a chronic condition. And this is all information. These references are are listed at the back of the presentation, but this is all right from the AMA. Stable for the purposes of categorizing medical decision-making is defined by specific treatment goals for an individual patient. A patient who is not at their treatment goal is not stable, even if the condition has not changed, and there is no short-term threat to life or function. It's hard to say. For example, a patient with persistently poorly controlled blood pressure for whom better control is not, the goal is not stable. Even if the pressures are not changing, the patient is asymptomatic. The risk of morbidity without treatment is significant. Examples may include well-controlled hypertension, non-insulin dependent diabetes, cataracts, benign prostatic hyperplasia. These conditions are usually not going to resolve, and they will be with the patient throughout their life. Next slide. So these are some, I've included these for your references. We're not going to be delving into these, but I just wanted to put some question and answers in for around the medical decision making. This seems to still be a, and these are things that I've already addressed in this presentation about prescription drug management related to MDM. Coders, auditors, and coding educators are looking for a consistent tool. The AMA has given us their criteria as far as their bullet points on how to use the tool appropriately to go to the medical decision-making levels. So this will be in the packet for you to review as well. If we could just go to the next slide to show the answer. Again, there was no way I could cut these down without losing content. So I just wanted to make these available in the slide presentation to make sure that you had this detail for your reference. As you can see, there's no blanket guides. They keep referring back to the MDM criteria that was given to us in January. This question I wanted to include here is multi-specialty physician practices. And I feel that, you know, a lot of us might be in that area where you have more than one specialty, especially in the internal med. You might have a woman's health, you might have a pediatrics, you might have behavioral health, all within the same specialty. So I wanted to include this question as a reference for these slides. And if we could just go to the answer. Again, these are right from the AMA to try to help give you a little bit of concrete information around the MDM and the E&M guidelines. And then I believe we have one more question to review. And I just wanted to, this one is about the data category to a physician in the same specialty. You find a lot of those answers, a lot of those questions and areas of concern in this kind of a group. So I wanted to include this as well. And then if we just go to the answer, again, it's very long. You do not want me to sit and read this to you, but I did want to provide the question and answers for your review. Again, documentation is key. As a coder, as a reviewer, as an auditor, practice manager, it is we're singing the song every day. Our technology that we have at Calm Waters will help again, but we can only go as well as it's being documented by the providers. Our technology will help with the problems of select and accurate E&Ms. Our technology never has a bad day. It does read the chart like a human, and it will recommend E&M levels, which may be missed by a coder, a physician, or somebody filling in the role to send the bills out. But again, I can't stress enough about how important it is for the providers to give us the accurate documentation for all of this information, just for the capture of the care that was provided to patients. And in the know, the AMA recently sent out a survey and found out that it takes 2 minutes, 11 seconds per E&M visit to code just the E&M portion. So what Calm Waters as an application does is that we do it in under 18 seconds. And I'm going to ask Joe to give you a little highlight of what Calm Waters is. Joe?
Great. Well, thank you so much. Thank you so much, Nancy. So really, you know, great presentation and appreciate the knowledge transfer. So the goal that we have was to help physicians right at the time of charting to establish a compliant, defensible E&M level. And so right from the physician's chart, our goal is to read the chart in real time and provide a very accurate defensible E&M level. So we do it in under 20 seconds all the way through the process, and provide your physicians and your providers or your designees clear and very accurate and very precise E&M level right at their desktop, really with the goal of accuracy, compliance, speed, but also helping the physician save time on every visit and give them time back in their day. I joke with maybe the goal the doctor actually gets to have lunch today. Next slide, please. So just a couple, we have a few screen highlights in here, but what the system's doing is it's reading the chart. It's automatically determining, the type of patient, the type of visit, what type of service was being provided, whether there was direct, indirect, ACP time being calculated. And then we have quick cheat sheets on here where if a provider's doing an ACP, the time is required to be noted. Next slide. Again, we have an established patient with an on-site visit, and this happens to be a very long on-site visit of 104 minutes. But one of the good things here is where there is requirements, we're always going to show. And since this is a real-time process, when your doctor's documenting, when they click the button and maybe they didn't put time in, and they see that this is a time required service, they're still in their chart. The chart is still open. They just close this window and they're back in the chart where they can take corrective action. Next slide. So the landing page, and this is as far as the physician needs to go, or the authorized individual. But the system automatically calculates through the AMA guidelines, and we're actually using the CMS AMA forms. And the AI engine automatically fills all this out and generates all of this automatically for your practice or for your facility. So we calculate both, go back one, please. We calculate both MDM and time concurrently. And then we obviously grab the diagnosis codes. Not that we code them, but we grab them from the billing system. But we do this all automatically and very, very quickly. So if we want to find out how, the system automatically reads the chart just like a human, and it automatically addresses the problems addressed, reads the chart, and scores it appropriately. Next slide. And reviewed and analyzed is obviously very complicated. This is a hallmark of our system, is being able to, again, read the chart, fill in the boxes, and create the defensible E&M level. But more so, this entire document becomes a PDF that is returned to you for both training. And should you have an audit or a chart request from a payer, it's already filled out for you. So you just need to fax it, email it, however it needs to make it back to the payer. Next slide. And then we do the same for patient management and summary. And now we're back to the summary. This happens to be a different summary. Here we can see that we have both time and we have prolonged time, which takes us from a level 4 under MDM, but takes us to a level 5 on a time-based service, and we get prolonged units here. So, these are complicated. There's two things, I guess, under the 2023 rules or new guidelines. One is, I think it gives us a lot more flexibility to be able to provide care like a provider wishes to provide care. So we can do that annual wellness visit with a sick visit. We can have the time spent with patient. We get credit for all of this, and we get to get paid for all of it. The issue now is that it's more burdensome for the provider to know how to be up to date on all the rules and make sure that they're capturing all the services. So in this instance, we have a 99215, we have a 99417 +4, and we have a GO439 all at the same time. And what we're finding is this is really difficult, not only for our physicians, but even for our coders. We look for production, we look for a certain number of charts every hour, every day. And we're having, AI technology that does it all automatically, I think really is a boon for the provider and all the staff. So next slide. Questions? Well, it was about 31 minutes, so we're all ahead of schedule. I might have spoken a little quickly, my apologies. But we covered a lot of complex issues, a lot of complex questions. So I'd love to hear any questions you have, anything that we might be able to answer for you.
We do have a few that have come in, so I'll just kick it off. What is meant by total time for office and outpatient E&M services? What do you guys mean by that?
You're on mute, Nancy.
Find the button. Can I unmute her? No. I can't unmute you, Nancy.
Wow, did I bore everybody?
Oh, whoa. I was worried there for a second.
Wow, okay, yeah, that's great. Oh, Nancy's done talking. Okay, so that's a great question. The total time is on the date of encounter. So a provider will review documentation from outside sources, as well as spending some face-to-face time. And it's called direct and indirect time, or face-to-face and non-face-to-face time. And the one of the things is a challenge, and I understand that. And right now, it's the most compliant way to go, is that the provider basically needs to add up how much time they spend reviewing the documentation prior to the visit, and then how much time they spend with the patient, and then it's added together. The cautionary note on this is that if you have, say, 10 patients a day, because it's easy math, and you say you spend an hour, 60 minutes with every patient, that's 600 minutes. Did you actually spend 600 minutes in the clinic that day on that, for that data service? So you just have to be aware that if it is ever audited and they're looking for one data service, if there's 24 hours a day and you say you spent 27 hours of reviewing, no time, no sleeping, no anything, that's where it gets a little concerning for an auditor. So just be aware that it's supposed to be within reason of how much time you spend for that calendar day, not to exceed the normal practice of your everyday schedule.
Awesome.
Does
Thank
that
you.
make sense, or did I confuse it a little bit more?
It made perfect sense. All right. So one more question here. Could you elaborate on the MDM risk of complications for patient management in a little more detail, please?
Sure. Yeah, the patient management one is a little bit more difficult to comprehend. This is where the physician will sit and discuss with the patient and or family any major elective major surgery, so a knee replacement, a hip replacement, or any open procedures, endoscopic procedures, and minor with identified risk factors. So minor procedures might be cataracts, or not saying cataracts is necessarily a minor procedure, but the major and minor point of this is how the anesthesia is actually administered. So anything that is general anesthesia carries a greater anesthetic risk and more possible risks due to that procedure. So any surgery is technically major or minor, but I mean major. It really depends on the administration of anesthesia and how quickly the patient is expected to return out of that. Addition is prescription drug management. So that is another one that falls into the patient management category. Therapeutic nuclear medicine. This is another one that increases the overall risk of patient management. IV fluids with additives. So just getting saline would not. However, if you're getting saline with a slow drip of an antibiotic or a prescription drug, that creates a higher risk of patient management as well. And then close treatment of fractures without manipulation. So that is overall increasing of the patient management MDM risk. Does that make sense?
Great. Do you have anything to
Yeah,
add
yeah.
to either one of those, Joe?
No, absolutely not. I'm going to leave that to the professionals. So I'm an IT guy at heart, so.
All right, let's see. We have a time for a couple more questions here. So Nancy, could you explain the self-limited or minor problem for clarification, please?
Yes, absolutely. Yes, I can. I had to think about that. So the AMA puts out that a self-limited or minor problem for is one that's going to run a definite course. It's going to be resolved fairly quickly. It's going to be it's not going to hinder the patient, permanently alter their health their health status. I'd like to say a simple cold, but colds can turn into things like that. So a simple self-limited minor problem, scrapes, bruises, simple lacerations that might just need a couple of stitches, butterfly clips, types of things like that. That is a self-limited or a minor problem.
Okay, and we'll take one more here. Let's see what I've got. Can ACPs, advanced care plans, only bill in physical exams?
No, actually, you can bail that on top of a physical exam and or other other visits that are being done in an office. So one of the main requirements for the ACP is that you have to meet or exceed at least 16 minutes, and it has to be documented. ACP, advanced care planning, is when the provider will discuss end of life, MOLST exams, MOLST. I know my accent might contribute to not hearing that accurately. DNR, DNI, things like that, or the patient's wishes about extubation and intubation. And as long as it's documented with at least 16 minutes or greater, then the provider can add an ACP E&M level on top of whatever services they're already performing.
Okay, how about one more? And then we'll
Sure.
wrap up. Sound good?
Sure,
If a nurse sees a patient for only a weight or BP check, is it billable?
absolutely.
Oh,
Oh,
that was
did you want
easy.
further?
Okay.
No. No, absolutely. So it is a minor problem. It sounds easy, but the nurse can bill for a low level 99211, and that it will be, basically just the weight or like a blood pressure check. It is
Okay.
the lowest level of an E&M on an established patient.
Thank
But
you.
yes, absolutely.
All right, I'm going to close it up. Thank you guys so much for joining us today for this webinar. We hope you got a ton out of it. We appreciate your time. And if we didn't get to your question, then Nancy or a member of her team will reach out to you directly over the next week and ensure that we've addressed your question directly.